Hello, my name is Yoshie Sano. I'm an associate professor at Washington State University, Vancouver. In this presentation, I will discuss our research findings on how to create effective health messages for low-income families in rural communities. Rural families experience health inequalities compared to their urban counterparts. Their life expectancy is lower, mortality rate is higher, and the number of negative health outcomes is much greater than those in urban areas. In the current pandemic, we saw disproportionate spread of COVID-19 in rural communities, especially in areas with meat-packing industries. Vaccination rate is much slower and fewer in these areas. So rural communities face unique challenges. They are geographically isolated, may not have adequate transportations, and have limited healthcare professionals. Even if there are healthcare providers in the area, they may be far away. In addition, rural residents generally have lower education level and lower health literacy, and they are less likely to reach out to community resources due to a stigma and a rural mentality of valuing independent living. So given those cultural background, health communication plays a critical role to improve family health in rural areas. As an example, during the pandemic, the Center for Disease Control and Prevention disseminated multiple important health messages to Americans, including mask wearing, hand washing, social distancing, and vaccination. Because access to healthcare is limited, it is extremely important for rural residents to understand health information correctly and take an appropriate action in order to prevent the spread of the virus. Unfortunately, however, there is little knowledge on effective health messages for rural low-income families. Past research indicated that just disseminating information in a general form does not work. For a message to be effective, it has to be culturally appropriate, timely, and tailored toward the target audience. So in our study, we examined the factors which contribute to the overall effectiveness of health messages toward low-income families in rural communities. We tested health messages in 4 different domains: dental, food security, health insurance, and physical activity. But in this presentation, I will only focus on dental messages as an example. So our participants are a total of 75 low-income mothers from 9 states. The mothers were recruited from social service agencies such as WIC, SNAP, and also through referrals from other participating mothers. Criteria for the study were being a mother and having at least one child younger than 13 years living at home, having an income at or below 185% of the federal poverty level, and living in a rural county with an urban influence score higher than 6, or in the most rural county in that state. And 65% of the mothers were non-Hispanic white, followed by 12% of African Americans and 11% of Latinos and Hispanics. About little bit over 18% of family reported their annual income is between $10,000 and $15,999. Oh, there's one mistake here. Another close to 18% reported income being $5,000 to $9,999. So half of the participants were married, followed by 27% of being single, 13% of divorced and then widowed, and 10% of living with partner. 60% of participants had high school diploma or less. In order to test the effectiveness of dental messages, we first created 6 different test messages with a communication specialist based on general guidelines for health communication. They were also reviewed by our research team members. In these messages, we focused on cavity prevention by encouraging using fluoride. The messages varied by length, details, tone, and the speaker of the message. So here are the examples of dental messages. In all messages on this slide, a speaker of the message is a peer mother. So please pause the video now and then read them by yourself. Now, these 3 messages use the authority's voice. In this case, a dentist's voice. Again, please pause the video and then read them by yourself. So based on the 6 messages, our participants were asked to freely express their preferences and opinions regarding each of the messages, such as length, level of detail, voice, tone, and information about fluoride use and community. Among 75 participants, 8 mothers were interviewed in Spanish. Spanish interviews were first transcribed, then translated to English. Then the translation was verified by a bilingual researcher. Our qualitative analysis found 5 major themes: length and then detail, relatability, fluoride knowledge, local community, and trusted voice. So in this presentation, I will briefly summarize the most important findings. The first theme are length and then detail and relatability. In general, mothers preferred shorter messages that got to the point, as seen in the first quote. But many mothers expressed that it was also important how informative the messages were, and that if they kept their interest, length would not be an issue. So that second quote shows that sentiment. Most participants felt a connection with the speaker of the story of the mother who struggled and took actions to take care for her children. The first quote is an example of such comment. But they felt that the busy and pinched for money part was irrelevant. They did not see as useful to the actual oral health problem in question. So many mothers mentioned that they preferred messages which directly address the economic and the resource challenges related to a specific dental issue. Now, we are moving on to the message content, fluoride knowledge, and local community. Many mothers expressed that they do not understand what fluoride is, where it's found, and what its true benefits are. They expressed that they preferred messages which better explain the connection between prevention of cavities and fluoride. Many also expressed that they were unsure and uneasy about the necessary dosage of fluoride. We also saw that many mothers have challenges to accessing resources which may or may not even be available in their community. They expressed economic challenges like purchasing fluoridated bottled water and traveling to dentists who accept their insurance. In addition, many moms said that they weren't sure about the quality or content of their community waters and expressed a need for educational messages. Many also mentioned that they prefer messages which are informative and provide facts about the specific community problems and alternative solutions for those problems. The final theme emerged was about trust. Most mothers said that the source of information should be from a dentist rather than a peer. They appreciated the relatability carried through the voice of other mothers, but it was more important for them that the message came from someone of authority. But I should mention that the mother's preference for authority voice was specific to dental messages. For other messages, such as food security, they preferred peer voice rather than educators. So it appears that their preference depends on who they trust most for a specific topic. So in conclusion, first and then foremost, our findings tell us that it's important to work with, not for, rural low-income mothers to develop effective dental messages. Because rural populations are diverse, a same message may not work for mothers with different background or living in different communities. For example, Latina mothers may respond to the messages very differently than non-Latina mothers. However, overall, these findings can help us develop and tailor health messages which increase reception, education, and promotion of health behavior. Rural areas need flexibility and resources to develop solutions. Prevention is the most powerful tool we have to reduce health disparities while working systematically to increase resources such as affordable and sustainable professional care in rural communities. So thank you very much for listening my presentation. If you have any questions, please contact me directly at the address shown on this slide. Thank you.